Importance of Demodex in dermatology is the topic of discussion for this video. Hello dear students, myself Dr. Maddineni Srinivas. Welcome back to my YouTube channel. So let us begin the discussion. So this was a theory question which was asked in the DNB examination December 2025 in paper 4, right? So we are going to see the discussion of the Demodex, which is basically a commensal which lies over the skin. So this is going to be present especially in the pilosebaceous unit of the mammalian skin, and it is a obligate ectoparasite, and it is going to be present in highest concentration in 20 to 30 years of age group because the sebum production is highest in that age, and it is rarely observed in the children under 5 years of age because of the immature sebaceous gland activity in the children. Cutaneous disease associated with abnormal increase in the mite density or host immunological flare-ups are collectively called as demodicosis. Okay, this is the term which you have to remember. The increased population of the Demodex is called as demodicosis, and it is very important and few important skin conditions which we are going to discuss. But before that, you should be knowing that there are two types of Demodex. What are those? One is Demodex folliculorum and the other one is Demodex brevis. So few differentiating points related to this. Demodex follicularum, it is going to occupy near the hair follicle, that is follicular infundibulum. Over the scalp, it is going to be the surface, the pore, near that pore we are going to see the presence of this Demodex follicularum. And if you examine with the dermatoscope, we are going to see that it is going to be present in a head down position in the hair follicle, where the tip of the striated abdomen is going to be visualized, as you can see in this picture, and it is going to be larger when compared to the Demodex brevis. So in the anatomy, you know, anything related to brevis is short. So Demodex brevis is short, and it is going to occupy the sebaceous glands and also the meibomian glands of the eyelids, and it is going to burrow deep, and it is going to be present in the sebaceous duct. It eats on the sebaceous sebum. Okay, it is present in the sebaceous ducts. And coming to the site, specifically follicularum, it is going to be present primarily over the face, whereas coming to the brevis, it is going to be present over the chest, upper back. So here and over the back, it is going to be present, and prevalence of follicularum is very common when compared to the brevis, and it is going to feed directly on the epithelial or follicular skin cells, whereas the brevis is going to feed mainly over the in the sebaceous glands in the sebum. Right, these are the differences between these two, Demodex follicularum and brevis. Coming to the life cycle and the biology, so the Demodex is going to have its birthday over the skin, and also its death is also in the skin only. So it is, everything is in the skin, especially in the pilosebaceous unit. And what is the timeline? It is going to be for a period of 20 days. The total lifespan is 20 days, out of which from the egg to the adult it is going to take approximately 10 days, and additionally it lives for 10 more days. So it is 20 days. So mating, everything, eating, feeding, everything takes place in the pilosebaceous unit, and it's going to crawl over the skin literally with the speed of 8 to 16 millimeters per hour. It's very, very slow, and that too it likes to roam around only when it is very dark, so there should not be any light. So these are some requirements of the Demodex, right? So we want to be in a house, okay, with all the amenities like kitchen, washroom and a TV, okay, Wi-Fi. So likewise this is also having some requirements, one of which is it should be very dark for it to come out, right? And you can see that scabies mite is also something, you know, it in the night time only it is going to produce the excessive itching, nocturnal itching. So likewise this is also having that nocturnal type of stimulation. And next is decomposition. So like I have told you, the birth and the death, all of them occur in the pilosebaceous unit. So it is going to degrade in the pilosebaceous unit, and ultimately it is going to release the highly immunological fecal waste and also endosymbiotic bacterial proteins. So this endosymbiotic bacteria, what is the name of that? If you know that, you put it in the comment section. I will tell you in the upcoming part of this video itself. In the pathogenesis, it is very important. So now coming to the pathogenesis. Most individuals are going to be completely asymptomatic carriers. In you and in me also, this mite is going to be there if we look under the dermatoscope, but we are not having any issues whatsoever. But progression from the subclinical colonization to active clinical disease, that is demodicosis, is involving multifactorial breakdown of the host parasite equilibrium. That is, we as a host and the mite, the Demodex as a parasite, we are in equilibrium. There is no problem for us produced by the Demodex mite, but there will be some situations in which this equilibrium will be disturbed, right? So what are all those things? First and foremost, the most important one is the increased density, increased population of the Demodex is very important. Okay, that is responsible primarily. Rest everything you can see in this mechanical blockage. So there will be over proliferation and dense packing of the mites within the narrow follicular infundibulum. So there is a small opening from the hair, from which hair follicle is coming out, so that will be completely blocked. So this is going to cause the sebaceous ducts also to get blocked, and also it will lead to follicular hyperkeratosis, distinction and subsequent rupture. Ultimately the follicle will rupture, right? And because of all this, what happens, there is going to be so much of waste, metabolic waste, and also the skeleton of this mite, all of them are going to come in contact with the host immunity, because of which there will be immune system activation. So this is going to lead to the innate as well as adaptive immune responses to get activated. Both humoral as well as cell mediated immunity are going to play a very crucial role, and it is triggered basically, like I have told you, the metabolic waste and also the structural proteins of the mite. So all this is going to cause the activation of the immune system, and like I have told you, there is going to be this chitinous exoskeleton which is going to be released into the dermis because of the rupture of the follicle, right? Because of which there is going to be this type 4, that is delayed cell mediated hypersensitivity being activated, which is going to lead to the granulomatous reaction, which is going to be visible on histopathology. And like I have told you, this endosymbiotic bacteria, which is Bacillus oleronius, which is present in the GI system of the Demodex mite. Okay, so that is also going to be released into the dermis, because of which there is going to be this stimulation of the toll-like receptor 2 upregulation, and also there is going to be cathelicidin activation, and a hyper-inflammatory response is going to be seen because of this. So that was about the etiopathogenesis, pathology, what is happening in the skin. Now we'll get back clinically what are the types of demodicosis. So there are two types, primary and secondary. So remember, dear students, if the skin involvement is de novo, we are going to call it as primary demodicosis. If it is due to other underlying causes, we are going to call it as secondary demodicosis, right? So we are going to see what are the important differences, differentiating points between these two. So in the primary demodicosis, it is going to be usually late onset manifestation clinically after the age of 40 years. Whereas secondary, it could occur at any age, because underlying cause could be anything, like for example, it could be immunosuppression, HIV, in leukemias also it could occur. So leukemias can occur in an age group, and also chronic renal failure, right? And it could be iatrogenic because of the prolonged usage of the corticosteroids, both topical as well as systemic. One more point to remember here is topical calcineurin inhibitors, that is tacrolimus and pimecrolimus, even they could also be one of the underlying trigger for secondary demodicosis. So please make a note that don't think that it is only the topical or oral steroids which could cause this. Even the calcineurin inhibitors, if they are used for long term, they could also produce this immunosuppression, and EGFR inhibitors, right? So primary it arises spontaneously, there is no requirement of any pre-existing concurrent facial dermatosis, whereas secondary it is going to have some kind of underlying local or systemic immunosuppression. Primary, it is a natural age related shifts in the sebum composition or the skin barrier function. So because usually in the later age there is going to be a problem in the barrier function, so that is also going to play a role in the primary demodicosis, right? And in the secondary, you can also remember that there could be a pre-existing rosacea on the top of which this Demodex could cause a more inflammatory response. Perioral dermatitis could also be there, and also seborrheic dermatitis. These are the other inflammatory skin conditions which could be associated with secondary demodicosis. Symptoms are going to be usually very mild, localized facial itching in primary, whereas it's going to be more extensive inflammation because already there was some underlying condition. On the top of this, it is Demodex which is going to produce more inflammation. Therapeutic response. So in the primary, you should remember purely anti-inflammatories like for medication, that is doxycycline, are not going to be helpful. There should be some kind of a specific acaricide which has to be used in the primary demodicosis, and in the secondary it requires both targeted therapy and also the whatever is the underlying cause, we should also handle that. Then only there is going to be improvement in the patient's condition in the secondary, right. Next, what is the spectrum of the Demodex associated cutaneous disease? What are all the conditions which could be associated with Demodex? Important ones we are going to discuss, and this number is also important. We have till now told that Demodex mite population is going to increase. So what is that number which you have to remember? Yes, that is greater than 5 mites per follicle or greater than 5 mites per centimeter square on biopsy, obviously. So this is implicated in several distinct facial eruptions. So first condition which you are going to see is the pityriasis folliculorum, also called as spinulate demodicosis. So here we are going to see the face is going to become obviously red because of the inflammation. Along with that, there is going to be some scaling, and nutmeg grater or sandpaper like appearance, texture of the facial skin will be also seen in this condition. So this is the sandpaper like texture which is better palpated than it is visualized, and also you can see erythema is there, and also there is scaling, right. What is the problem here? It is highly associated in the females who rarely wash the face and also use a lot of makeup. So basically all this is going to cause a lot of food to eat for the mite which is present on the skin, and in fact facial cleansing is also very important, which will remove at least physically whatever excessive mites are present. But because these women are not practicing this daily ritual, daily routine, that is the reason why the population of the Demodex is increasing in them, right. Next condition is the rosacea, again very important, papulopustular and also granulomatous rosacea. So how is it going to present? Asymmetrical distribution of the inflammatory papules, pustules, persistent erythema and telangiectasias are going to be present, especially on the central third of the face. And also there will be increased density of the Demodex mites, and if you take a biopsy, we are going to see the foreign body granulomas present adjacent to the follicular infundibulum. Next is blepharitis. The eyelashes can also be affected. So it is ocular rosacea. It is considered a type of rosacea where there is going to be eyelid margin irritation and also burning and crusting can be seen. There will be loss of the eyelashes, that is madarosis can also be seen, and recurrent chalazion can also be observed in these patients. So this is the Demodex mite, and this is the involvement with the crusting present in the eyelashes, and here you can see this is the inflammation, that is a blepharitis. So in this Demodex follicularum, it nests in the eyelash follicles, and Demodex brevis, it blocks the meibomian glands. So ultimately it is going to cause the gland dysfunction, and it will lead to decreased tear breakup time. So the tear breakup time is usually going to, like for example 10 seconds, but because of this Demodex brevis it is going to reduce, and now the tear is going to break very fast, like in 2 to 3 seconds, because of which there is going to be excessive dryness of the eyes, right. Next is steroid induced rosaceae eruption. So those individuals who are on some potent topical steroids, if they suddenly stop that, there is going to be this pustular flare up of the face, and yeah, it is associated with chronic steroid abuse. This is going to suppress the immune system locally, leading to the unchecked proliferation of the Demodex and also the Cutibacterium acnes. Okay. Next, Demodex folliculitis. The patients are going to present with discrete, very itchy acneiform pustules over the face, neck and the upper trunk. So again, it is characterized by, if you do a biopsy, we can see the neutrophilic and lymphocytic infiltrate near the infundibulum. So how can you diagnose? What are the diagnostic modalities which we can use? So standardized skin surface biopsy, SSB. Standardized skin surface biopsy. Here very interestingly what we are going to do is, over a glass slide we are going to put the glue, okay, cyanoacrylate glue. I hope you know this is going to be used commonly in the medical field. So and then we have to press this firmly onto the facial lesion, and we have to peel off, and we will apply the mineral oil and observe it under the microscope. So this is what is called as standardized skin surface biopsy. What are we going to see in the microscope? So basically this is a diagnostic gold standard for identification of the density, how many are there in a given area. To identify this is the best option. Of course this is a number which I have already told, this much number. If it is more than this, then we can call it that it is Demodicosis. Of course we can also observe this directly under the KOH mount also. And how is it going to appear? It will have 4 pairs of short anterior legs, and it is going to have a straight posterior body, as you can see in this picture. So these are the 4 anterior pairs of the legs which are very short, and this appears to be somewhat same like the scabies mite, but in the scabies mite it was 2 pairs of anterior legs and 2 pairs of posterior legs, and the organism, it was appearing like a turtle or a tortoise, right? Next we have this dermatoscopy. Here it is a non-invasive. We are going to just observe like a magnifying glass just applied with pressure on the skin. So it is in vivo magnification. So here we are going to see the presence of the Demodex tails near the follicular infundibulum, as this translucent structures protruding from the follicular orifices. Very interesting. And at the follicular openings we can also identify that there could be this brown colored plugs which could be surrounded by erythematous halo. So this is the another picture which is showing the follicular openings. If you do a biopsy, of course we are going to identify the Demodex mites present near the dilated infundibulum, and follicular hyperkeratosis and surrounding perifollicular lymphohistiocytic and granulomatous infiltrate can also be observed, right? So now coming to the therapeutic modalities which we can use to control the demodicosis. So but before that, just like is going to motivate me. Please do that like button. Also do hype if this video is helpful. So coming to this treatment part. So what is going to be the goal of our management, our treatment? So primarily to reduce the population of the Demodex, that is the first one, and also to repair the skin barrier which is compromised, and also we should reduce the inflammation. So these are the goals which we want to achieve with the treatment. So what are the options which we have? Obviously the specific treatment, that is going to be the antiparasitics or acaricide medications which we are going to use. They are Ivermectin 1% cream. This is the first line of choice in the treatment of demodicosis, which is going to be applied as a thin layer over the entire face once daily at the night for a period of 2 to 3 months. And also we can use the permethrin 5% cream. It should be applied once weekly for a period of 2 to 3 weeks. Benzyl benzoate 10 to 25% we can use as an appropriate concentration, because it could irritate the facial skin. Crotametron 10% applied once daily at the night time. So these are the antiparasitics which could be used. Apart from this, topical anti-inflammatory agents like for example azelaic acid 15 to 20% and metronidazole 0.75 to 2% can also be used. So both these should be applied twice daily. These are basically having anti-inflammatory properties. And systemic agents which we can use are importantly oral Ivermectin. In the case of severe immunocompromised suppressed states, we can use this as a dose of 200 micrograms per kg. So it comes around to 12 mg in a 60 milligrams individual. It should be repeated after 1 week, right? Oral metronidazole can also be used 250 mg orally 3 times daily for a period of 2 weeks. Oral tetracycline. So now this is very interesting. Even in the rosacea also we use this, isn't it? In the demodicosis also it is used. The doxycycline, minocycline, 100 mg 200 mg per day for a period of 4 to 12 weeks. And this is interesting, this could be examiner's favorite question. So what is the use of the, why are we using this doxycycline? Because the endosymbiotic bacteria Bacillus oleronius, which is present in the GIT of the Demodex, that is the target for this medication, right? And it will deliver anti-inflammatory properties also by inhibiting the nitric oxide and also matrix metalloproteinases. So I hope this video was helpful in your understanding of the Demodex and the skin. It's a 5 marks question, so you may not be able to write everything. So you can just mention very important points as a short note, and this may also be asked as the 10 marks. So again, revise this, and we'll meet again in the next video soon. Please hit that like button, also do subscribe if you are not yet done. So in the comments you can ask any queries you are having. Thank you so much. Happy learning. Bye bye.